Good evening, everyone, and welcome. We're excited to have you here today with us for this webinar, BoneMRI Surgical Precision with Zero Radiation and Efficient Workflow. My name is Dionysios Yogos. I'm the Product Manager at MRI Guidance, and I will be your host for today's session. We are joined today by Peter Sivning, MRI Guidance co-founder and Chief Scientific Officer, and also with Dr. Jacob Rumley from the Center for Spine Orthopedics in Denver. Unfortunately, Dr. Pulstra was scheduled to join us from Southern Hill Hospital in Las Vegas. He got caught in unexpected surgery and couldn't make it today. It was last-minute cancellation, as often happens in this case in the OR. So we hope to have him join a future session with us. But for today, what you should expect in the next hour. Peter will start with an introduction to the bone MRI technology, and then Dr. Rumley will share his experience, how he integrated bone MRI into his surgical workflow with the 7D flash system. And after the presentation, the floor will be open for Q&A session, but feel free to post your question in the chat at any time, and we'll address them as many as we can during the talks or at the end. Today's session is being recorded, and we will share the replay for you afterwards. And with that, let's get started. It's my pleasure to hand it over to Peter Sivning, who will kick us off with an introduction to the bone MRI technology. Peter.
Thank you for the introduction, Dionysius. I'm excited to dive right into the presentation and share some background on the BoneMRI technology before our experts discuss their initial experiences. So I will share my screen now. See. I think you can see it here. Yes. Yes, very happy to share some of the background of the BoneMRI technology. So as you all know, musculoskeletal treatment management heavily rely on imaging. And when patients come in with lower back pain, with neck pain, often X-rays are first being made after an anamnesis. Then it's often followed by MRI scans. And in case of surgery or surgery being eligible, preoperative planning can be done using CT scans, and we see more and more intraoperative navigation also based on 3D imaging performed during the operation. And what we see here is that this actually is quite an inefficient workflow with multiple examination, increasing cost, and not always leading to the most optimal preparation and potentially leading to increased operating times. What we also see here is that 3 out of 4 imaging modalities here are X-ray based, which means that there's a threat for not only the patients for getting cancer at later age, but also for physicians in the operating theater using the intraoperative imaging. So what we think here is that there's a need for more efficient and safer, smarter imaging solutions for spine treatment management. And with BoneMRI, we have developed such a technology. So BoneMRI is a machine learning algorithm that allows us to generate CT-like images, the BoneMRI images, from clinical MRI images as shown on the left. So these bone images are 3-dimensional, they're sub-millimeter accurate, and they're quantitative, which means that they really provide Hounsfield units, which correlate with bone density in the same way as a CT scan. So what we also generate with this algorithm is an improved soft tissue contrast, T1 weighted contrast. And that makes this algorithm really efficient because in the end, it balances out the additional scan time. And that's important for the radiologists. Finally, it also allows you to generate 3D models as shown on the right, which are helpful for educational purposes, but also to get a better view of the patient anatomy, just to be better prepared for surgery. So that makes this technology a multi-contrast synthetic imaging technique, which is applicable to all kinds of vendors, different MRI machines, Philips, Siemens, GE, different field strengths, 1.5 and 3T, and provides a one-stop shop to visualize all the bone and soft tissue for surgical planning and navigation. So a bit more about this algorithm. It's important to understand that this algorithm has been trained on thousands of patient data sets, paired data sets, where we have MRI data of the same patient as the CT scans. So this is used to train that convolutional neural network. And I think it's also important to mention that this is not a generative algorithm. We've all learned about generative AI in the last years, and well, there has been a lot of talk about hallucinating effects of generative AI algorithms. That's not what we are using. We're using a supervised learning method based on a convolutional neural network. So once such a network is trained, it's frozen. It's not learning while being used in your clinic. So it means that it then can receive new unseen data, as shown on the left, the two bone MRI source images. They go in the algorithm and they generate the CT-like images shown on the right. So this is a seamless workflow that can work in your hospital once it has been installed. And this technology is currently CE marked, FDA approved for the total spine as well as for the pelvis for adults and adolescents 12 years and up. So these certifications, what do that actually mean? Well, that means that the bone MRIs are validated in terms of their morphological accuracy and voxel-wise accuracy. The morphological accuracy means that if you would compare a CT scan with a bone MRI scan, and you segment it, shown by the red and the blue line in the image on the top left, you can calculate a point-to-point surface distance, the distance between these lines. Based on that, you can come up with the accuracy, and that's what has been done in thousands of patients, and it's shown that this accuracy is around 0.4 millimeter, so that's sub-millimeter accurate. The claim that we make is that it should be within 1 millimeter, so that is way within that range. In terms of the radio density, that means the voxel values that correlate with bone density, it is close to 10 Hounsfield units off, which means that's in the noise of an average CT scan. So this allows you to use this data in a secure way in your surgical planning and navigation. So how does it work in your hospital? BoneMRI has a specific protocol that needs to be installed on the scanner, shown on the left. This is a 4-minute protocol or a little bit less, dependent on your scanners. And once that has been installed, your technician can do that with a bit of help of us by sending some parameters. The data is scanned on the MRI scanner and sent to your PAC system. While there in the PAC system, these bone MRI scans are recognized by a piece of software that's part of our product. That's called the Gateway. This is FDA approved, HIPAA compliant. And that Gateway de-identifies the data and it sends it to the cloud in the US, where it's reconstructed into a 3D bone MRI. That 3D bone MRI is then sent back to the gateway from the cloud, where it is re-identified in the gateway again within the hospital walls, and then it's sent back to the PAC system. Well, there a radiologist can look at the data, and you as a surgeon can also use the bone MRI data next to the normal MRI data to look both at soft tissues as well as osseous structures, pathologies from a single examination. So there's many different actions you probably perform in your daily routine, like treatment planning for the assessment of the implant sizes and the plan that you actually want to use to execute your surgery. Maybe you're using 3D printed anatomies or 3D printed guides, or use more advanced navigation tooling. All these different aspects currently rely on the 3D quantitative parameters and characteristics of a CT scan, and that can all now be done on the bone MRI scans. So there's a multiple number of stations and navigation systems compatible with the bone MRI, among which the 7D flash system, which will be elaborated on by Dr. Rumley, but also BrainLab, the Globus Excelsius robotic system, and the Medtronic navigation system, the Mazer system, are all compatible with the BoneMRI technology. And I just added a few slides as 10 minutes ago we learned that Dr. Poelstra will not be in this presentation. This is one of his slides, and just to show how his workflow with his Mazer system works. So what he's doing, he requests an MRI scan of his patients. Then a bone MRI reconstruction is being made, shown on the top left. On the bottom left, you see how he's using this data to make a pre-operative plan the day before the surgery. And then during the surgery, they are well prepared. Staff is well prepared. He has all the implants and the sizes he needs in his operating theater. He doesn't need a big OR machine there. He doesn't need another person operating that machine because he uses just 2 fluoro shots, AP and lateral, to do a 2D, 3D image merge of the pre-op bone MRI plan with the intra-op anatomy of the day of the patient. So in that way, he circumvents the need for intraoperative 3D imaging. You can still use your navigation. You have 3D information. And in the end, he does use some fluoro shots to confirm the implant locations. And in this workflow, it saves him 20 to 30 minutes because he doesn't need the intraoperative imaging. And he estimated that it will probably save him about 90% of the radiation burden for the patient, but obviously also for the operating staff not utilizing the intraoperative imaging. Another group recently assessed this, and this will be published in the European Spine Journal, in a larger group of patients, comparing a standard clinical workflow with a pre-op CT and an intraoperative imaging O-arm run, compared with the bone MRI pathway, where you use bone MRI pre-operatively. What they found is that on average, you use 9 to 10 millisieverts on a patient on the standard clinical pathway, half of it due to the pre-op CT, half of it due to the intraoperative O-arm images, compared to about 0.1, 0.2 millisieverts due to the fluoro shots used for the bone MRI pathway. That means you accomplish a 98% radiation reduction in a bone MRI-based pathway. Maybe also interesting is another navigation methodology just based on 3D printing. You can obviously print the 3D anatomical model, but also shown on the right, surgical guides. And this was the system of Mighty Oak, the Firefly system. This was tested in cadavers, and in the meanwhile, this is used clinically, where these drill guides uniquely fit on the different vertebra. And in that way, you can navigate your surgery based on 3D prints. Another example of 3D prints used, this was done by Cedars-Sinai. On the left, the bone MRI image. Panel B shows the bone MRI reconstruction. In the middle, a 3D rendering. And on the right, from 2 sides, the actual 3D printed model. And this is very helpful, not only for the surgeon, but also for educational purposes of the people involved, parents of a child, for example. So that wraps up my part of the presentation. Thank you all for your attention. And just a reminder to everyone, if you have any questions along the way, feel free to drop them in the chat, and we'll cover those at the end. Now I'm excited to hand it over to Dr. Rumley, who will take you through his experience on integrating bone MRI into his surgical workflows. So Dr. Rumley, I will stop sharing my screen.
Perfect.
And feel free to take it over.
All right, thank you. Let me get this put on. Here you go. All right, how's that look? Does that all look great?
Perfect.
Let me stop the audio recording. Okay, so thank you everybody for having me. I'm Jake Rumley. I'm a orthopedic private practice surgeon outside of Denver, Colorado, and we have an AO fellowship down here, initially started by Mike Jansen, big arthroplasty guy. And I've been fortunate enough to be a part of this fellowship program for now 5 years, and trying to lead the cutting edges. Like arthroplasty was cutting edge, in the early 2000s. We've been trying to find the thing that's truly going to impact patients in a different way. And I think that BoneMRI has been the thing to do that. I'm here specifically to talk about 7D flash system and BoneMRI. 7D flash system I'll go into a little bit more in depth, but in the end, this is a perfect marriage. This is exactly what spine surgery should be trying to become. It's truly radiation-free surgery. I started as a open trained freehand surgeon doing, a lot of deformity surgery, doing all these with biplanar fluoroscopy. I was not a navigation guy. I was actually probably the most anti-navigation surgeon in this market because I felt like it was plagued with inaccuracies and workflow issues. Mostly the fact that a lot of cases I'd seen, somebody would accidentally bump the array, and then we'd be doing another 3D spin, taking extra time, just irradiating patients, and something we don't talk about, irradiating the surgeons at a pretty high rate, increasing infection risks, in my opinion. A couple of studies have led to believe that that's the case. Then I came to 7D flash navigation. So this, I think, is a perfect marriage because the 7D flash navigation is 100% based off of optical 3D cameras that take a photograph and create a 3D image that then initially would then take that to a CT scan and overlay them to allow for navigation platforms to be used. Initially, as a open surgeon, I was worried that there was going to be a lot of stuff in the room and it was going to slow me down. The picture on the right is a case that my fellow and I are doing. Actually, when the BoneMRI first started, we have two guest surgeons in the room standing in the back corner. There's a fluoro C-arm sitting under the surgeon's right shoulder. My back is to the screen. We have an image up. That's all that's in the room. That's how large this navigation system is because the light is built in. With this, I didn't have to worry about stepping out, waiting for a spin and all that. It was truly radiation free. And we took an x-ray for localization, then 2 x-rays at the end to confirm. So at this point, we were getting no intraoperative radiation because we could step out for that. And with an x-ray, the risk is so low, especially when you have lead, which now I don't always wear, and an x-ray shield. Because the thing that people aren't talking about is the exposure to the surgeons, not just the patients. Surgeons in spine tend to get cataracts, high-risk tumors, female surgeons and male surgeons getting breast cancers, things like that. There's certainly things that have raised my awareness because I'm 44 years old and I don't want to be exposed to this because I've had a few mentors get pretty significant cancers from their biplanar exposure. The other thing that I liked about it is it allows, and it's not changed at all with BoneMRI, it allows for navigation on demand. So I can take the array off. I can put some screws in if there's a complication, maybe a dural tear, maybe the patient's not doing well, we have to close quickly, something like that. I can take it off, anesthesia gets them under control, we can keep going. In my case, somebody can bump the array. It doesn't slow me down. We just reflash. There's no need for respin. So truly, it's nice because I can change. I can do a T-lift and do more screws below if I don't want to put them all in right in one go, which is decreased blood loss. Then secondly, I have fellows operating under me, which if you don't have fellows, can be terrifying at times, but it allows for more of the hand of God. I can watch exactly what they're doing, and they can train in an open setting. So the fellow in this case is looking over his shoulder to see what the imaging looks like because he's doing it freehand. I'm still teaching them how to do it without technology so they can do it the correct way. For my workflow for this 7D system, which has not changed at all with the BoneMRI, is the patient arrives with preoperative imaging. Typically in the private practice setting, this extra scan does not come standard with my patients because it comes from a primary care or pain management. So then I send them for that bone MRI. I like to also do this so I can confirm they don't have any hardware in place that would affect the quality of the MRI. You can't use this with ferrometallic implants. Then when we send them for this MRI, we have yet to have a patient denied by an insurer for the additional MRI, even if they have a previous MRI, because this is for navigation. It is only in our experience with the imaging center. At first, it was taking 4.5 minutes. Now it takes 2.5 minutes for them to get this MRI scan. It's crazy fast. And then I'm able to take that MRI, it uploads into our system, and I don't plan the day before typically because we have all the screws that I could want in-house, all the implants I want in-house. I am right before the case sitting down and doing my preoperative planning for my screw pathways. So I know exactly what we can have. And I actually can have all the screws on the back table lined up, ready to go from our preoperative plan. 95% of the time, those are the screws that end up going in. So this is hyper efficient. Here's the picture of us doing a bone MRI case during the FDA clearance. I'm operating with those ridiculous loops. I've switched away from those. And we're doing a case. We are looking in the wound. We're not looking at a screen. We're doing a surgery like surgeons, not letting something else do the surgery for us. And we are confirming with this 7D navigation. You'll also notice there's really these rooms look massive because we don't have a giant O-arm. We don't have lots of extra instrumentation in the room. We have exactly what we need to do these deformities. So when we're doing the surgery, the preoperative plan is on the left. This is for a patient who had an old prior scoliosis surgery back in the day when they just did onlay bone graft and maintained the curvature. She had relatively poor bone and she had significant degeneration at L5S1. So we planned a lumbopelvic fusion. So the bone MRI scan on this looks perfect. It looks no different than the CT scan. So during this FDA study, we were planning with the CT, we were confirming with the bone MRI, then using both to navigate. And here we are picking our points. Then this is the points where it correlates perfectly. Each one of those green dots shows exactly where we have a spot on our bone MRI, our CT scan, and the patient from the 3D photograph that perfectly coalesce. So from this patient, we're using both the CT and the bone MRI. We're flipping back and forth, replacing screws. And I mean, in real time, this goes very quickly, but we were able to also use something called a reslicer where we can take these deformities and bring that into a perfect axial cut, which can kind of help, especially my fellows, and at times me, be able to view that trajectory of the screw, whereas previously with fluoroscopy, you would struggle for quite some time, especially in a patient with no bony landmarks. This is really a game changer. When we're replacing screws in patients with significant deformities and large osteophytes, there are times when you'll feel down and you don't have a endpoint. In this case, we're able to feel down and we know that we have plenty of bone anteriorly because we're placing the screw into an osteophyte. So it's removed some of those concerns and stressors during surgery that you just can't explain based off of their preoperative imaging. So for me, the learning curve was not based on bone MRI. My learning curve has really been based on learning how to do navigation because I was not a navigation surgeon. One of the advantages of using this software and system is that we can navigate what's called a segmental registration. So we can use preoperative MRI imaging and place the array on each level, and then you can do a large deformity correction and still be able to navigate each level without affecting it. You can do an anterior based surgery, then flip them over the same day. And as long as you segmentally register off of each of these levels, using this software, we can actually place screws without getting an O-arm spin, even though we've significantly changed the anatomy from the preoperative scan by just going off of each vertebral body. So when we agreed to do this, we agreed to do the FDA clearance. We did 10 cases in 2023. We obtained both a CT and a bone MRI. The image on the left is the bone MRI. The image on the right is the CT scan. I will tell you, I was quickly a fan of the bone MRI because to me that actually looked like what I was looking at. It was less granular and it was not affected by obesity. My BMI cutoff ideal is under 35. Those sometimes are over 40, have cauda equina, things like that. This has made it so that I'm not affected by obesity. And it actually makes the navigation significantly better. Sometimes even fluoroscopy can be nearly impossible with these obese patients. When we navigated with the bone MRI, we then confirmed with the CT scan. We were also told to only do lumbar pedicle screws, but I'll show you in a minute. It works for everything. We were able to place all these screws with no change. In fact, I preferred it. When we first started, the biggest kind of pain point was it took a week for us to get these reconstructions back from because we'd have to put them on a disc, send them and come back. Now I've not had a patient that took 48 hours even. That's the longest patient we had one when it first started to get that imaging back. They get them back right away. And I operate through an imaging center. So I have multiple hospitals I work at. And these imaging centers are able to talk with the people at BoneMRI, set up a understanding, and then get this sent over quickly. It's really no delay. It's been quite impressive. I really didn't think it would work as well as it did. So far, like I said, zero denials, and the imaging centers actually kind of like this because they get at minimum, they get to charge for another MRI, and it takes them a fraction of the time. So they've been very on board. There's also potential CPT codes for some hospitals and whatnot that are able to be charged separately. That is a different CPT code that can help them with the billing because there's certainly cost associated with getting additional imaging. But this is in lieu of getting a CT scan. And to provide radiation-free experience for patients is very important. Like I said, my only images are the localizing and the final x-rays. Especially, I don't do pediatrics, but we know that the risk of a CT in a pediatric patient increases the risk of malignancy by 1.8-fold is the most recent thing I've read. They think that 1 in 10 pediatric hematologic cancers is actually due to imaging. Is kind of a sobering thought. So really, it's our duty to try to use this if at all possible. We think about children who have much more high metabolic activity and these early pluripotent cells. But in reality, we all have these. We're all at risk of these hematologic cancers and whatnot. So I think it's smart for us to give all of our patients that same respect. So my learning curve, here we go. First case. I did my first case and I was set. It did not take multiple cases to get this down. I had a 68-year-old male who had claudication and multi-level radiculopathy. EMG confirmed L1 through S1 radiculopathies. I don't think I've ever had that except for this guy, but every single level was a concern. He had multi-level stenosis. And after a long discussion with the patient, because we're going to have to do so many levels of decompression, and because he had this early kyphosis where he became autofused above, we planned on a T12 to pelvis. So for this case, using the navigation system, this is the bone MRI that we used. And this is early planning as we're looking at it because we spent a lot of time on these initial cases to make sure that the registrations were going to look correct before the surgery. We actually performed 5 separate registrations where we selected 5 areas of the bone to navigate from. We placed 14 screws with 7D navigation. Our registration time was 45 seconds. So it's way under 5 minutes. It's, I think, 3.5 minutes of total registration time. The time for screw implantation to include the pelvic bolts, I think, was 15 minutes, which is appropriate for an open surgery as well. And every single one of those screws was in a perfect osseous pathway. Most importantly, there was 0 radiation required for this. Because it was the initial FDA studies, we did have the other CT scan, but now when I use this, these patients now have really almost no radiation. They have x-rays, 2 fluoro scans. That's it. So in doing this, this is the bone MRI. We did a block registration of 2 posterior elements, selected our points, and it almost looks like somebody just put a highlighter on the bone, confirming exactly where the bone is. These registrations were perfect, and as you see on the left, I'm showing the registration for this block and how perfect that navigation is as we put it on. It's sub-millimeter accuracy with the bone MRI. Additionally, what I loved about it is I could see structures that I wasn't used to seeing on navigation: veins, dorsal root ganglions. It's just something you're not used to seeing. It was almost an information overload the first time I looked at it. It was so exciting. More importantly, vessels and vascular anomalies. It just seemed like it was so much safer. I almost felt guilty for not using it. Now, if I have a chance, I have to use it. It's just the right thing to do. Even when we had this S1 registration, which we purposely tried to not expose too much bone, trying to confirm that it would register off of small amounts, we still had sub-millimeter accuracy with this small segmental registration. Here we are placing screws. I will frequently say I have a planned screw where it should go, but when you look at the anatomy, just being an open surgeon, sometimes where you actually need to put it versus the navigated start point ends up being a little different. That may be a problem with me not being as commonly using navigation in my past, but right here we're able to put screws perfectly down osseous corridors, and you're able to see on these anterior structures, you can see the segmental arteries. It's just incredible. Down into the sacrum, I felt much more comfortable because I'm actually able to visualize the S1 nerve root, or sorry, the L5 nerve root easily, and know that I'm nowhere near it, because not all patients get the angulation of this screw, where it's very lateral to medial. Sometimes in very obese patients or narrow pelvises, you can have a direct in view, and you don't know where that L5 nerve root is depending on their pelvic anatomy. And I've taken out a lot of screws where surgeons have placed them in too laterally directed, and they've hit that nerve root. And I wonder if they would have had this, could they have missed that complication? We were also able to place pelvic bolts. So I place a medial start point iliac bolt. I don't do S2AI. I stay out of the sacroiliac joint. And with this bone MRI, you see the sacroiliac joint perfectly. It's actually been kind of exciting to see some of the more like edema concerns and things where you can actually see more arthritic changes than you do on the MRI. Additionally, once again, you see all the anatomy anteriorly, which can also be helpful, especially if you're considering uh, adding this to maybe a SI fusion type task. There's some work right now being done to make this so we can do these for SI fusions, and be able to see the L5 nerve root perfectly and the S1, things that you don't see on that CT scan. So in the end, this is a patient over a year post-op. Woke up, he had no pain. He was the happiest patient I've had in quite a while. Certainly didn't skimp on the length of my pelvic bolts. I try to put them in so they never fail. But this patient's surgery was made significantly easier because of the bone MRI. So much so that after the first case, I asked if I could just make this my permanent way of doing it. They made me stop at 10, and I had to wait for it to become market available. So for me, this has been an absolute game changer. I really can't, imagine doing this without, now that I've had it. It's like having the best thing you've ever eaten. Like here in America, we get some wonderful pasta, but you go to Italy and it's like, man, how did I ever think that stuff at Olive Garden was edible when I was 10? This is Italy. The old stuff was Olive Garden. So I think this is wonderful. And I'd like to thank you guys for letting me talk, and I'm willing to answer any questions as you guys come up with them.
Thank you, Dr. Rumley. So if you have any questions, mics are also open, so you can ask them directly to even Peter or Dr. Rumley.
If I can kick off. Thank you very much for this very interesting talk. You started off explaining that the radiation and ionization is something that's important for you. I think you also talked about some other aspects that are important and maybe crucial aspects that change with bone MRI. And then I think you were talking about workflow, teaching, inventory management. Can you elaborate a little bit more on how, for example, this could change your inventory management when you're better prepared?
Oh, absolutely. I think especially in a surgery center type setting, as far as the speed, accuracy, and whatnot, as you are planning screws ahead of time, certainly the number of screws available within a surgery center isn't always as great as it is in a hospital. There's certainly been times when I asked for a 35 millimeter, 40 millimeter screw, and they look at me and say, "Doc, we're out." That's always a concern. So it makes sure that you know exactly how many generally you have to have. I think that also with inventory management, for me, it has completely removed the need for an O-arm, which is a very expensive item because I no longer need that based off of these. So as far as the ability to improve the workflow, now I have screws loaded and ready to go in the back. I know I have enough screws, and our hospital's spending less money on each case.
That makes sense. And so regarding the O-arm that you just mentioned, I can imagine that not having to use that is also influencing the total imaging time. And I think that can also be important for from a cost perspective.
Oh, absolutely. I mean, I there are some other surgeons who still use the O-arm with some other systems, and the risk of infection and time because God forbid somebody actually bumps the array. Each of those spins adds another 10, 15 minutes to the point where now most of them just keep it prepped at the top of the field because it was adding so much time to their cases. I
Yeah.
certainly, going from an open surgery to this, it will not make you slower.
Okay, that's good to hear. Yeah, because that's an important aspect for adoption. So we have a question in the chat. Can you go over the reimbursement charges on scans the imaging center can charge? Does CAMS allow a second charge for bone MRI?
So for the imaging centers that I send to, the insurance companies, uh, because it's a navigation requirement, we put that in, and the insurance companies have been paying for the MRI. I can't tell you exactly what the code they're using is. I do not own any imaging centers, but I can tell you that they have been more than willing to perform these. And the feedback I've gotten from some of the medical directors over there are basically they love them. And for the radiologists, they like it because there's really nothing to read on these MRIs for them. They just put in a simple dictation of bone MRI for surgical planning. No obvious pathology has changed, so that's been very good for them.
Okay.
And I can ask you that I know that there's some work on the other CPT code for bone MRI. I don't know if you have any information on that.
Yes, I can say that from our perspective, there is a code G0566 that has been assigned to the bone MRI technology a few months ago, and we as a company are obviously now helping to start centers get this built because that's just how it works with new codes, and we still have to go through that learning curve a bit. But what we have seen, apart from what you explained, Dr. Rumley, is that there's other ways, like imaging centers or radiology centers, they can add the charge master for the additional time. And then there is the modifier 26 for if a reading is needed for the radiologist. That's the physician part of the code. So there's different ways, and we have reimbursement guides available for anybody who's interested in receiving that. Then there's one more question here. Can you talk about the extra vascularization you can see and how that saves you time and confidence in the case?
Absolutely. I would say the biggest thing with it is at first I thought it was just very cool to see, just because I'm not used to seeing that. But I can say in real life, a couple of things. One is in placing sacral screws. Certainly, I feel more confident, especially placing bicortical sacral screws, staying away from the bifurcation and confluence as the common iliacs come off. I'm less worried about that. I can tell you I've certainly been in a case or two where there was some significant bleeding as we went bicortically. I have elected a couple of times to just place a slightly shorter screw because of that, which made me more confident. And I can say in the thoracic spine or high lumbar L1, if I'm doing an in-out-in trajectory, if they have hypoplastic pedicles. There was a patient recently that they actually had a very large, I'd say vascular structure. I don't want to call it a segmental artery that was sitting right under the pedicle right there. Certainly that would have been a lot of blood loss into the psoas retroperitoneum. It just probably would have been more of a time than a patient danger issue. But then as you get up into the thoracic spine, certainly we know where the aorta sits. I don't think that I would ever place them long, but I actually have more confidence to put in longer screws than I maybe would have before. Of course, still following the same tenets of good spine surgery of feeling and not just blindly relying on the technology. But it is yet to be inaccurate for me.
Thank you. Any other questions from any of the contenders or Dionysius?
So actually, one thing I would add that is
Yeah.
helpful that I would throw out there that I didn't mention in my talk that I think is maybe a truly power. If anybody does tumor surgery, I think this is a nice thing as well because the neovascularization can sometimes be quite aberrant. And this isn't always just about placing screws. I think that could theoretically be helpful in maybe avoiding some bleeding and whatnot, and viewing tumor margins, things like that based off the MRI, which are not always obvious on CT. So sorry about that. That's just a thing that I thought is
Yes.
it could be great.
Yeah, that's a very nice addition. Obviously, on MRI you can very easily see all the tumors, soft tissue tumors, and then it's complemented with the bony information. Thank you very much. Dionysius, I leave it to you.
Yeah, I think we are good on time to close this one. So yeah, I see there are no more questions. So I would say this can bring us to the end of today's session. Just thank you again, Peter and Dr. Rumley, for your participation. I hope you found this today's session very valuable and inspiring, and we'll be sharing the recording with you by the end of this week. So on behalf of MRI Guidance, thank you again for your time and look forward to connecting with you soon.
Thank you very much.
Thank you, everyone.